Welcome to this concise video log on HIV and aging, bone health, and new HIV primary care guidance. This program is provided by Clinical Care Options and is supported by independent educational grants from Gilead Sciences, Merck Sharp and Dome Corp, and Vive Healthcare. This vlog was recorded by Dr. Monica Gandhi. Before we begin, please note her disclosures on this slide. This vlog is part of a comprehensive educational program on caring for aging patients with HIV. You can gain CME, CE, or CPE credit for viewing these vlogs and download the slides by visiting our website, clinicaloptions.com.
Hello, I'm Dr. Monica Gandhi from UCSF. I just saw an older woman in my practice with HIV who is experiencing some health challenges that I often encounter. I'd like to share some details about this case, in particular around bone health and primary care recommendations for older patients with HIV. So Lisa here is a 67-year-old woman with a history of HIV diagnosed in 1997. She actually had a heart transplant in 2008 after long-standing CHF due to postpartum cardiomyopathy. Her antiretrovirals was an old PI regimen at the beginning, but then she was switched to efavirenz plus TDF-FTC in 2001 and switched to the single pill combination of efavirenz TDF-FTC in 2006. She has been on that regimen until 2018 with good virologic suppression, but we changed it in 2018 because of questions of her bone health after a DEXA. And her CD4 count is 643. Her HIV viral load has always been undetectable. She has no mutations and her BMI is 24. So I want to talk a little bit about what made me switch the TDF and why we went to abacavir, dolutegravir 3TC, which is what we switched her to in 2018. ART initiation is associated with a 2 to 6% decrease in bone mineral density over the first 2 years after living with HIV. That is actually the same decrease that you can see postmenopausal in cisgender women. And because of ART's effects on bone, specifically the tenofovir-based regimens, and HIV itself, in fact, there are increased fracture rates in people living with HIV. And the causes of low bone mineral density in people living with HIV really are multifactorial. They're an interplay between HIV, established osteoporosis risk factors, and antiretroviral effects, specifically the tenofovir-based regimens. We do perform a fracture risk assessment tool, or the FRAX, which gives us a 10-year probability of a major fracture. And the fragility fracture risk with FRAX is assessed essentially by things like age and sex, race and geographic location. You want to look at BMI, you want to look at current tobacco smoking, parental history of hip fracture, alcohol use, rheumatoid arthritis, or other secondary causes of osteoporosis, long-term use of glucocorticoids, which our patient Lisa had because of having a heart transplant. She was on low-dose prednisone, and frailty, fall risk, and physical inactivity, which would contribute to the risk of fracture. Certainly, the FRAX score can be used with and without DEXA, but really what I want to point out to you today is our current recommendations on when to perform a DEXA scan. This is important because sometimes we have to remember that we have to be way more aggressive about DEXA screening in people living with HIV than people without. It's not recommended to do this until a certain age, but the age groups, when you want to screen with a DEXA, are much younger for people living with HIV than without. So the recommendation is all adults with HIV who are in women postmenopausal, or men over 50 years of age. And that is different from the recommendations from the general population because HIV itself is a risk factor for osteopenia and osteoporosis. And certainly you want to speed that up if there are any signs of endocrine disorders, renal disorders, GI disorders, or hematologic disorders that would have caused secondary osteoporosis, as shown here on the right, or if there's any history of a fragility fracture. So there are two things that happened this year. The HIV guidance was recommended for primary care guidelines. This was published in CID at the end of 2020. And though it is not that different, these guidelines from before, there is an emphasis on bone health. We want to perform HIV routine labs, certainly screen for mental health, evaluate blood pressure, STD screening, maintenance of our vaccinations, cervical and anal cancer screening, and routine labs and patient education. But the emphasis on bone health is published in a recommendation, again in CID by Todd Brown and others. This is shown on the next slide that I already went over the bone mineral density recommendations for DEXA screening. We also want to remember that we should be performing lung cancer screening for any smoker who've had a 30-year past year of smoking. We want to think about varicella zoster vaccine over 50. Prostate, breast, and colon cancer screening are actually not different than those from the general population. So let's continue with Lisa's case. We did do a DEXA as recommended, and actually it did show in this particular case that she had met the WHO criteria of findings consistent with osteoporosis. The T-score in the lumbar spine was negative 1.9, and the total femur and femur neck was lower than that. So both age-adjusted and the T-score showed findings of osteoporosis as shown on this slide. So this led me to be concerned that Lisa's at increased risk for fracture risk. So I actually wanted to talk to you now, Lisa, and turn to you and say thank you for joining us. And if you could please tell me about how you felt when we talked about your bone scan results.
Well, I was very concerned because I did not want to fracture any of my bones. And unfortunately, a few years ago, I did have my first fracture. I slipped on a rug in my home and I broke the little finger on my left hand. So that was my first fracture. And then I started researching how to keep my bones healthy. I started researching that I should be exercising and doing weight-bearing exercise that would help strengthen my bone, that I should be walking. And I wanted to make some adjustments to my diet to see if there were particular foods that I could eat that would help strengthen my bones.
Great, that's perfect. And, you know, we talked about at the time that you had been on the brand name etripla, but efavirenz TDF FTC for a long time. Yes. And we wanted to discuss that we were having discussions about, for a variety of reasons, switching you off that regimen, and wanted to see what you thought about that when we first started discussing it.
Well, initially, I was reluctant to change because I had been on the medication for so many years and I was stable and always had been stable. So in my mind, I was thinking, well, if it works, why are we changing? If I go to a different retro antiviral, I may become unstable. But you talked to me about why you wanted me to change, and you guaranteed that I would continue to be stable. And that has been the results of me changing. I have remained stable. And as a matter of fact, the new medication that you put me on, it doesn't make me sleepy. So I can take it any time of day. I could take it in the morning or at night. The previous medication I was on, it would make me sleepy. So I could only take it at night.
Yes, I think we really wanted you off that TDF because of its effects on bone. And luckily, since 2018, because of your excellent adherence and how you are with your medication taking, you've been doing extremely well. And we didn't have those CNS side effects of the efavirenz. Yeah. So, you know, the concern here is it wasn't just around switching her off TDF, because at this point, your risk for fracture was higher because of this T-score of basically in the negative 1.0 to negative 2.5 range. And so what we did is do a workup for other causes of osteoporosis. We checked thyroid. You had no smoking causes. You certainly were on prednisone, just the low dose, but for the heart transplant. We optimized, like you said, your calcium and vitamin D intake. You encouraged your own physical activity. You were not a smoker. And we, recommended by the slide here, we did start the IV bisphosphonate, ended up giving you a once a year IV bisphosphonate. And that we can talk about later about how that was, but I'll go over a couple of issues around the next slide here, this ART considerations. We didn't want you on TDF anymore. You weren't on PI-based regimen at this point, but we didn't want you on TDF anymore, and we switched that. And essentially, what we're watching for, because you had the fracture that you just told us about, is no more fractures. We want to watch your DEXA and ensure that it increases in terms of its bone mineral density. And we are going to ensure that we give you this bisphosphonate for 2 years. How was the osteoporosis treatment for you? We already talked about how your ART regimen change was, but how was it, the once a year infusion?
Well, I went to the infusion department, and I had an hour-long infusion. The nurse did explain to me some possible side effects. She said that I may have flu-like symptoms, or I may have a headache or some deep bone pain. And in a couple of days after the infusion, I did have flu-like symptoms, and I did have some deep bone pain. Those were the two side effects that I experienced.
And then luckily, it's only once a year. And
Yes.
what I want to talk about on this next slide is, to be clear, the current recommendations that were put in the CID guidelines are actually somewhat vague about when to perform repeat DEXA screening. So we actually turned to the European AIDS guidelines, which we want to give you here, to show that, of course, we address fall risks, but they're more specific about when to consider the repeat DEXA, which I agree with. The continued osteoporosis screening, we do continue to check calcium, and you're taking calcium and vitamin D. We do a FRAX risk assessment every 2 years, but we will be doing your DEXA screening now to confirm after the 2 years of treatment that it looks stable, or hopefully and very likely improved. And so that, I think, is the recommendation that I would go with, is that once you start therapy, you want to do DEXA screening every 2 years on bisphosphonate. Bisphosphonate certainly itself needs to be reevaluated constantly to decide when to stop it. But usually we will stop it after 3 to 5 years. And so in terms of how you're doing, I actually think that your bone health is improving likely as we speak, because you're on the bisphosphonate, you're taking the calcium and vitamin D, you've increased your physical activity, we've taken you off the TDF, and I wanted to see if personally, you are, as you know, one of my most compliant, adherent, great patients, always ask great questions. You're always coming in with good ideas. And I wanted to see if you wanted to say anything else about your bone health and how you're doing now. I know you've had a hard year in other ways, but how you're doing now with your bone health?
Well, as I age, I want to stay active, and I don't want to injure myself where I have to be sedentary. And so I want to remain active. And I think that I've managed to do quite well at my age. I don't have any signs of arthritis or any problems that seem to be developing with my bones or my joints. So I hope to be able to continue feeling well. I feel very young. Even though I'm in my 60s, I feel
yes.
like I'm 35. However, that I attribute that maybe to my young heart that I received 13 years ago. So
Yes.
I received the heart of a 25-year-old man. And so I was told that cells and tissue have memory. So perhaps my body perceives my heart as being young, and that's why I have energy. And I'm able to do a lot of things despite my 60 some odd years.
Yes, I think you're doing great, and I'm really proud of you. And I'm glad you're doing well in the new regimen. And thank you so much for joining us today.
You're welcome. Thank you.
Thank you.